Welcome everyone to my presentation on Hanox Conline Purpura. I am from University of Gondar. Hanox Conline Purpura. Hanox Conline Purpura. Hanox Conline Purpura is the most common vasculitis of childhood. Is characterized by leukocytoclastic vasculitis and immunoglobulin A deposition in the small vessels in the skin, joints, gastrointestinal tract, and kidney. According to the 2012 International Chapel Hill Consensus Conference nomenclature, Hanox Conline Purpura is also referred to as IgA vasculitis, based on the presence of vasculitis with predominance of IgA deposits affecting small vessels. Hanox Conline Purpura. Epidemiology. Hanox Conline Purpura occurs worldwide and affects all ethnic groups, but is more common in white and Asian populations. The incidence of Hanox Conline Purpura is estimated at 1420 per 100,000 children per year and affects males more than females, with a 12 to 18, 1 male to female ratio. Approximately 90% of Hanox Conline Purpura cases occur in children, usually between ages 3 and 10 years. Hanox Conline Purpura is distinctly less common in adults, often have severe and chronic complications. Hanox Conline Purpura is more common in the winter and spring and is unusual in the summer months. Many cases of Hanox Conline Purpura follow a documented upper respiratory infection pathology. Skin biopsies demonstrate leukocytoclastic vasculitis of the dermal capillaries and postcapillary venules. The inflammatory infiltrate includes neutrophils and monocytes. Renal histopathology typically shows endocapillary proliferative glomerulonephritis, ranging from a focal segmental process to extensive crescentic involvement. In all tissues, immunofluorescence identifies IgA deposition in walls of small vessels, accompanied to a lesser extent by deposition of C3, fibrin and IgMSE. Figure 192.2 Girl with Hanox Conline Purpura. A. Typical palpable purpura in lower extremities. B. Skin biopsy of the lesion shows direct immunofluorescence of IgA, arrows, within the walls of dermal capillaries. Pathogenesis. The exact pathogenesis of Hanox Conline Purpura remains unknown, given the seasonality of Hanox Conline Purpura and the frequency of preceding upper respiratory infections. Infectious triggers such as Group A beta hemolytic streptococcus, Staphylococcus aureus, mycoplasma, and adenovirus have been suspected. The common finding of deposition of IgA, specifically IgA1, suggests that Hanox Conline Purpura is a disease mediated by IgA and IgA immune complexes. Hanox Conline Purpura occasionally clusters in families, suggesting a genetic component. HLA-B34 and HLA-DRB101 alleles have been linked to Hanox Conline Purpura nephritis. Patients with familial Mediterranean fever, hereditary periodic fever syndromes, and complement deficiencies are at increased risk for developing Hanox Conline Purpura, suggesting that genetically determined immune dysregulation may contribute clinical manifestations. The hallmark of Hanox Conline Purpura is its rash. Palpable purpura starting as pink macules or wheals and developing into petechiae, raised purpura, or larger ecchymosis. Occasionally, bullae and ulcerations develop. The skin lesions are usually symmetric and occur in gravity-dependent areas. Lower extremities. Extensor aspect of the upper extremities or on pressure points, buttocks. The skin lesions often evolve in groups, typically lasting 3–10 days, and may recur up to 4 months after initial presentation. Subcutaneous edema localized to the dorsa of hands and feet, periorbital area, lips, scrotum, or scalp is also common. Musculoskeletal involvement, including arthritis and arthralgias, is common, occurring in up to 75% of children with Hanox Conline Purpura. Arthritis tends to be self-limited and oligoarticular, with a predilection for large joints such as the knees and ankles, and not lead to deformities. Periarticular swelling and tenderness without erythema or effusions are common. Arthritis usually resolves within 2 weeks but can recur. See Figure 192.3 Hanox Conline Purpura. Gastrointestinal, GI, manifestations occur in up to 80% of children with Hanox Conline Purpura. Include abdominal pain, vomiting, diarrhea, paralytic ileus and melena. Intussusception, mesenteric ischemia, and intestinal perforation are rare but serious. Complications. Endoscopic evaluation is usually not needed but may identify vasculitis of the intestinal tract. Renal involvement occurs in up to 30% of children with Henox-Conline purpura, manifesting as microscopic hematuria, proteinuria, hypertension, frank nephritis, nephrotic syndrome, and acute or chronic renal failure. However, progression to end-stage renal disease, is uncommon in children. 1 to 2%. Renal manifestations can be delayed for several months after the initial illness. So close follow-up with serial urinalysis and blood pressure monitoring is necessary. Neurologic manifestations of Henox-Conline purpura, caused by hypertension, posterior reversible encephalopathy syndrome, or central nervous system, CNS, vasculitis, may also occur, including intracerebral hemorrhage, seizures, headaches, depressed level of consciousness, cranial or peripheral neuropathies, and behavior changes. Other, less common potential manifestations of Henox-Conline purpura are inflammatory eye disease, carditis, pulmonary hemorrhage, orchitis, and testicular torsion. Diagnosis. The diagnosis of Henox-Conline purpura is clinical and often straightforward when the typical rash is present. However, in at least 25% of cases, the rash appears after other manifestations, making early diagnosis challenging. Most patients are afebrile. Table 192.4 Classification criteria for Henox-Conline purpura. European League Against Rheumatism or Pediatric Rheumatology. European Society criteria. A palpable purpura, in absence of coagulopathy or thrombocytopenia, and one or more of the following criteria must be present. 1. Abdominal pain, acute, diffuse, colicky pain. 2. Arthritis or arthralgia. 3. Biopsy of affected tissue demonstrating predominant IgA deposition. 4. Renal involvement, proteinuria greater than 3g or 24hr, hematuria or red cell casts. Classification criteria are developed for use in research and not validated for clinical diagnosis. Developed for use in pediatric populations only. The differential diagnosis for Henox-Conline purpura depends on specific organ involvement but usually includes other small vessel vasculitides, infections, acute post-streptococcal glomerulonephritis, hemolytic uremic syndrome, coagulopathies, and other acute intra-abdominal processes. Additional disorders in the differential include papular purpuric glove and sock syndrome, systemic lupus erythematosus, SLE, other vasculitides, urticarial, hypersensitivity, and thrombocytopenia. Infantile acute hemorrhagic edema, AHE. An isolated cutaneous leukocytoclastic vasculitis that affects infants 2 years of age. Resembles Henox-Conline purpura clinically. AHE manifests as fever, tender edema of the face, scrotum, hands, and feet, and ecchymosis, usually larger than the purpura of Henox-Conline purpura, on the face and extremities. The trunk is spared, but petechiae may be seen in mucous membranes. The patient usually appears well except for the rash. The platelet count is normal or elevated, and the urinalysis results are normal. The younger age, the nature of the lesions, absence of other organ involvement, and a biopsy may help distinguish infantile AHE from Henox-Conline purpura. See Figure 192.4. Infantile acute hemorrhagic edema. Typical lesions on the arm of an infant. Laboratory findings. No laboratory finding is diagnostic of Henox-Conline purpura. Common but nonspecific findings include leukocytosis, thrombocytosis, mild anemia, and elevations of erythrocyte sedimentation rate, ESR, and C-reactive protein, CRP. The platelet count is normal in Henox-Conline purpura. Occult blood is frequently found in stool specimens. Serum albumin levels may be low because of renal or intestinal protein loss. Laboratory findings. Autoantibody testing such as anti-nuclear antibody, ANA, is not useful diagnostically except to exclude other diseases. IgA values are often elevated but are not routinely measured. Assessment of renal involvement with blood pressure, urinalysis, and serum creatinine is necessary. Ultrasound is often used in the setting of GI complaints to look for bowel wall edema or the rare occurrence of an associated intussusception. Barium enema can also be used to both diagnose and treat intussusception. Although often unnecessary in typical Henox-Conline purpura, biopsies of skin and kidney can provide important diagnostic information, particularly in atypical or severe cases, and characteristically show leukocytoclastic vasculitis with IgA deposition in affected tissues. Treatment for mild and self-limited Henox-Conline purpura is supportive, with an emphasis on ensuring adequate hydration, nutrition, and analgesia. Corticosteroids are most often used to treat significant GI involvement or other life-threatening manifestations. Glucocorticoids such as oral prednisone, 1-2 mg or kg or day, or, in severe cases, intravenous, 4-methylprednisolone for 1 to 2 weeks, followed by a taper. Reduce abdominal and joint pain, but do not alter the overall prognosis. Corticosteroids are not routinely recommended for the prevention of complications such as nephritis treatment. Rapid tapering of corticosteroids may lead to a flare of Henox-Conline purpura symptoms. Although few data are available to demonstrate efficacy, intravenous immune globulin, IVIG, and plasma exchange are sometimes used for severe disease. In some patients, chronic Henox-Conline purpura renal disease is managed with a variety of immunosuppressants, including azathioprine, cyclophosphamide, cyclosporin, and mycophenolate mofetil. End-stage renal disease develops in 5% of children with Henox-Conline purpura. Nephritis complications. Acutely, serious GI involvement, including intussusception and intestinal perforation, imparts significant morbidity and mortality. Renal disease is the major long-term complication, occurring in 1 to 2% of children with Henox-Conline purpura. Renal disease can develop up to 6 months after diagnosis but rarely does so if the initial urinalysis findings are normal. Therefore, it is recommended that children with Henox-Conline purpura undergo serial monitoring of blood pressure and urinalysis for at least 6 months after diagnosis to monitor for the development of nephritis prognosis. Overall, the prognosis for childhood Henox-Conline purpura is excellent, and most children experience an acute, self-limited course lasting on average 4 weeks. However, 15–60% of children with Henox-Conline purpura experience 1 or more recurrences, typically within 4 to 6 months of diagnosis. With each relapse, symptoms are usually milder than at presentation. Children with a more severe initial course are at higher risk for relapse. The long-term prognosis usually depends on the severity and duration of GI or renal involvement. Chronic renal disease develops in 1 to 2% of children with Henox-Conline purpura, and 5% of those with Henox-Conline purpura nephritis go on to have end-stage renal disease.